the topic I'm Chiang from Kaohsiung Veteran General Hospital. And the topic I'm going to present is pharmaco-induced vasospasm embolotherapy for lower GI tract bleeding. And we know that GI bleeding is one of the major causes for hospitalization, accounting for 1 to 2% of admission, with a very high death rate up to 25%. The incidence could increase with age, patient, multiple comorbidities, such as renal failure or hematological or malignancy, and some patients with anticoagulant use. GI bleeding can complicate clinical courses of critically ill patients. The definition of acute significant bleeding is bleeding requiring transfusion of more than 4 units of blood within 24 hours, or vital sign instability or shock. We know that lower GI bleeding is defined as the bleeding point is located distal to the ligament of trace, accounting for 20 to 25% of all GI bleeds. And about 25% of the bleeding began after hospitalization for another disease. The common presentation of lower GI bleeding, including intermittent, multifoci, self-limiting, and about 10 to 15% patients may require intervention. And we know that the CTA is now the gold standard for diagnosis for low GI bleeding. And the mortality rate is about 3.6%. The common causes of low GI bleeding are diverticular bleeding, angiodysplasia, ischemic colitis, or chronic IBD disease, and so on. And there are some direct signs or indirect signs in angiographic findings for acute GI bleeding diagnosis. The direct signs is the active extravasation of contrast median into the bowel lumen, like this one, the pointer. Sorry. Oh, the pointer is here. So like this. This is an active extravasation. And sometimes we cannot, there is no active bleeding. We can observe some indirect signs, such as aneurysm, shoulder aneurysm, like this one, or some vessel irregularity, abrupt vessel cutoff, or some AV shunting, or sometimes only parenchyma brush, like this one, and some dilated arterial and early venous bleeding, like in angiodysplasia patient. And CTA is now promising as a first-line diagnostic modality because of its wide availability, and the CT can be performed very rapidly. CTA can also help us to guide endoscopic, endovascular, and surgical management. CTA is composed of 3-phase examination, including the non-contact phase, arterial phase, and the venous phase, to allowing us to catch the moment of active extravasation, like this one, active extravasation, and the flow, and the contrast flowing into the bowel lumen. For embolotherapy for low GI bleeding, what is the target vessel to be embolized? We know that the mesentery of small bowel and the colon was composed of marginal artery and the vasa recta. And there is an important animal study that using MBCA glue to do the artery embolization. If less than 3 vasa recta were embolized, the chance to get ischemic bowel is about 25%. However, if more than 5 vasa recta were embolized, the bowel necrosis is inevitable, 100%. So embolization involving the 3 or fewer vasa recta of the SMA branches was relatively tolerable and safe. However, in human, when we do a super selective TAE for the low GI bleeding with MBCA, when only one single vasa recta with 1 branch was embolized, there is no ischemic change. However, if single vasa recta with more than 2 branches were embolized, the chance to get ischemic change is about 75%. Most of them may be self-limited. However, if multiple vasa recta like this one was embolized, the chance to get ischemic necrosis is 100%. If, for example, in our case, the SMA angiography shows an active extravasation at the ascending colon. So, however, we were unable to reach our microcatheter was unable to reach the vasa recta. So, a microcoil was put at the nearby marginal artery. 30 days later, the patient got sepsis, and the CT revealed overt bowel necrosis and perforation. So marginal artery embolization does carry very high risk of bowel ischemia. When we do a low GI bleeding TAE, we need to be very super selectively to identify the active extravasation point, identify the active breather. We need to insert our microcatheter all the way from the SMA orifice, from the IMA orifice to the vasa recta, and confirm the breather, and slowly and gently, carefully inject MBCA glue, prevent overflow and non-target embolization. The procedure can be done very safely. However, it's very time-consuming and skill-demanding. Even with a super selective approach, ischemia remains a concern. When we do a super selective approach with PVA or glue or coil, the bowel ischemia rate is about 70%, and the bowel resection rate is about 13%. If we do empirical TAE for the low GI bleeding, like this one, he used some coil in the marginal artery. The ischemia leading to bowel resection rate is about 25%. However, also the major post-embolization complication really occurred, and the vascular therapy is still the first-line approach over surgery in profuse low GI bleeding patients. However, if the TAE is still mandatory for this patient, is there any better method to stop bleeding temporarily without permanent vessel injuries? We accidentally encountered a vasospasm event when we're doing this procedure. The patient has active bleeding at the cecum. Angiography, SMA angiography shows active extravasation. However, the parent feeding artery was too tortuous that we were unable to insert our catheter and guide wire into the feeding artery. After several attempts, the feeding artery got vasospasm, and the whole territory, including the marginal artery and the vasa recta, all the vessels got the vasospasm immediately, and the bleeding stopped immediately too. And 2 days later, the follow-up and SMA angiography shows all the vessels were extension without no more active extravasation. All the marginal artery and the vasa rectus remains intact. Therefore, we started to develop the pharmaco-induced vasospasm and bowel therapy for low GI bleeding. The rationale is to temporarily squeeze the parent artery that supply blood to the bleeding area. In combination use of CTA angiography and intra-arterial MDCT, like angio-CT we say in Taiwan, and that we can confirm the correct parent artery territory. It is only a semi-selective technique, easy technique, and it can be easily conducted in local hospitals or by trainees. We use bolus epinephrine, about half to 1 milligram, followed by pitresin 4 to 5 units per hour for 4 to 5 hours. And the embolization time is equivalent to the new embolizer, quick soluble gelatin sponge particle embolization time. And it can be repeated when recurrent bleeding is suspected. We usually use the vasospasm and bowel therapy in patients that when we were unable to reach the breather, when the breather is multifocal bleeding in one territory, or the CTA is positive but the angio is negative for empirical embolization. How to use the combination of CT and angio-CT. For example, in this patient, he got a massive bloody stool with active ileal loop bleeding detected by our CTA. In the CTA, we show active extravasation at the middle ileal loop. And please play the video. Please play the video. With the CT, with the thin slice CT or reconstruction CT, we can identify most of the major branches of our SMA. So like this one, we can see the SMA branch. The left side, the first branch, the second branch, the third branch, and the fourth branch turning right and going down all the way to the breathers. So we can make a direct comparison with our SMA angiography. The first branch, the second branch, the third branch, the fourth branch, turning right and going down to the breathers. So this with the combination of angio finding CTA and the angio and the intraoperative and CTA, we can precisely localize the culprit vessel and shorten our procedure time and probably save our patient's life. And in this case, we put our microcatheter into the culprit vessel territory and confirm the perfusion territory by our intraarterial MDCT. And after vasospasm and ball therapy, the patient has no recurrent bleeding for 6 months. Another case, the patient's CTA shows active bleeding at the ascending artery, active extravasation. So we insert our microcatheter into the ileocecal mesentery and using our angio-CT intraarterial MDCT to confirm the perfusion territory. And then vasospasm therapy can precisely focus on the bleeding territory. The patient has no recurrent bleeding for months. And another case, the patient has active extravasation at the descending colon. We insert our catheter into the descending colon branch. And after epinephrine injection, all the marginal artery and the vasa recta shows the extensive vasospasm, and the bleeding has stopped immediately. 24 hours later, relaxation of all the arteries with good bowel wall perfusion was seen. In comparison to superselect TAE, our published results showed that our success vasospasm and ball therapy success rate is very high, about 100%, and the recurrent bleeding rate is a little higher, about 26.5%, but with no any concern of bowel ischemia. And our primary result is the primary success rate is about 73.5%, and the overall clinical success rate is about 83.7%. And can we also perform empirical embolization for low GI bleeding? Because intermittent bleeding feature may render the angiography inactive even after positive CTA finding. Repeated prolonged uncontrolled hemorrhage may complicate with myocardial infarction, respiratory failure, septic shock, and multi-organ failure, especially in the aged multi-comorbidity patients. Further, if early massive rebleeding occurred, about 50% mortality rate could ensue. Therefore, empirical embolization for the low GI bleeding may be needed in some patients, such as, for example, in this patient. The patient got a massive low GI bleeding with hypovolemic shock. And the first time CTA was negative. However, the second time CTA 2 days later shows distal ileal bleeding. However, the SMA angiography is negative because the patient's perfused hypovolemic shock and all the vessels shows extensive vasoconstriction. Therefore, we place our microcatheter into the ileocecal mesentery and use our vasospasm and ball therapy. And the patient was survived. No recurrent bleeding for 4 years clinical follow-up. Another case, the patient has active extravasation at the hepatic fracture. However, the angio finding is negative. So we place our catheter into the middle colic artery for embolization for vasospasm therapy. The patient has no recurrent bleeding for 13 months clinical follow-up. We just published our results of empirical pharmaco-induced vasospasm therapy for GI bleeding. If the bowel segment belongs to a relatively fixed location, like the colon, we will insert our catheter into the corresponding artery. If the bowel belongs to a relatively movable segment, such as the jejunum of ileum, we can use a combination finding of angio-CT and CTA, of angio-CT, CTA, and angiography to precisely localize the culprit vessel. There were 23 low GI bleeding patients with positive CTA but negative angiography finding. 90 bleeders located in the SMA territory and 4 bleeders located in the SMA and IMA territory. The early rebleeding rate is a little higher, about 26.1%, but 100 technical success. And the primary clinical success rate is about 73.9%. The overall clinical success rate is about 91.3%, without any complication of bowel ischemia or cardiopulmonary distress. There are some authors in the literature. There are also some authors try to do the prophylactic TAE for low GI bleeding, and Chiang said Chiang used non-selective high-dose vasopressin infusion therapy via the SMA trunk for 2 days to treat the angionegative low GI bleeding. However, the result is worse when compared to the angiopositive group with a higher mortality rate because the high-dose vasopressin without precise localization provide little benefit. And another study used coil particles of gelatin sponge for the prophylactic embolization in angionegative patients. The bowel ischemia rate is 25%, leading to bowel resection. That's because without precise localization, risk outweighs benefit. And another study that he used TAE in angionegative patients, and the rebleeding rate is a little higher, but the bowel infarct rate is similar. However, in the observation group, in the angionegative patients, the rebleeding rate is much higher, about 70%. So prophylactic embolotherapy is effective and needed for management for low GI bleedings. However, the pre-angiographic localization for low GI bleeding is crucial for decision making. In comparison with the super-selective permanent, the permanent embolization is usually only recommended in angiopositive for therapeutic intent. Need a super-selective technique. It's very skill demanding and time consuming. Only can perform a single point treatment with risk of bowel ischemia. However, with vasospasm embolotherapy, it's only a temporary vasospasm. Can be used in angiopositive or negative patients with the therapeutic or empirical intent. Only a semi-selective technique is very easy and convenient. Can perform a short segmented problem. Risk of only have higher risk of recurrent bleeding, especially in high flow bleeding or coagulopathy patients. And both techniques need adequate resuscitation and transfusion and precise breather localization. Take-home message. Pharmaco-induced vasospasm embolotherapy is safe and effective for low GI bleeding for either active bleeding or empirical embolization. To avoid the repeated hemorrhage caused multi-organ failure, empirical embolization for low GI bleeding can be advocated. In combination of CTA angiography and IA-MD-CT, we can help IR to precisely treat the culprit territory. Thank you for your attention.